السلام عليكم ورحمة الله وبركاته. نشكر إخواننا في جمعية قسطرة القلب الخليجية على هذه الإتاحة فرصتنا لبعض الحالات من الأردن. Our case presentation with a 30 years old gentleman not known to have any medical illnesses. He was a smoker, strong family history of premature coronary artery disease. Patient come to the clinic complaining of typical chest pain, burning in nature, radiated to shoulder with associated short breath. He was conscious, alert oriented, heart rate was 82, O2 saturation was normal, and the blood pressure was very high. It was 170 over 100. So lab troponin was positive, kidney function normal, CBC, everything is normal. I started the patient on dual antiplatelet therapy and in beta blocker, ARBs and Crestor, rosuvastatin. And this is ECG on the clinic. If you see there is some changes with LVH criteria. And this is the ECG. I admit him to the CCU. It's more prominent that we have an LVH criteria with some changes on the lateral leads. So the echo was there is a severe concentric LVH with normal LV function, with the grade 1 diastolic dysfunction. And so I send him to the cath lab. This is our RCA. And then we go to the left system. We have a long left main. And this is our calibrate lesion, which we have around 99% stenosis of the LED. And there is some D2 disease, the proximal part. So we go to our routine management. We stent the LED by a drug-eluting stent 3.5 by 34 millimeter. And we post-dilate this one with a 3.75 by 15 millimeters to high pressure. And this is our result, final result. Do you have any notes?
Anyone? Quick note. Arif, Hamid, Amf, anything? No? Go ahead.
Okay.
We are happy.
After that, this is one of the pictures. And during removal of the J wires, this is during removal of the catheter and inserting the J wire, I see some staining on the coronaries. What's your opinions? Do you see this? This one. I see it, yes. So what we find, I have already my catheter is inside, I re-engage, then I do this. The patient is stable, no chest pain at all. I ask him, how are you? He doesn't, everything is okay. So ops dissection from left main to the D1. It's a big dissection. I have my wire on side. I put my wire to the. This is what's your opinions? What's next?
So your wire were inside. You
Yes.
didn't remove your wire.
No, it's out, but already on the cath lab, I was on the same.
You okay?
Yes, when I saw this staining, already I want to remove my guiding catheter. I re-engage and do these pictures. Yes, this is that I present this one. I saw this when I'm preparing my lectures. Really, I saw it yesterday. If you see this, it's retrogradely now. Retrogradely speaking, not on the. This is at the end of the. There is some. If you see, there's something like here. If you see, I saw it. But when I were in the cath lab, I didn't see it really. بس هو حماية من رب العالمين إنه I saw it. This happened. This one is happening. So I re-engage, and after that, حقيقة فن القسطرة اللي جنبي كان إيديه هيك. After that, what I do, the patient is stable, no chest pain. I send my wire, and then I put a drug-eluting stent 4 by 38 millimeter from the proximal part of our stent to the left main, and this is after stenting. Then I post-dilated by NC balloon by 4.5 by 15 millimeters to a very high pressure. But in spite of that, you look at this ostium, I don't like it. So I think nobody will argue to put a stent to the ostium. So I put a drug-eluting stent 4 by 12 millimeter, and with the stent flaring by the same balloon, which is a 4.5, 12 millimeters. Another post-dilatation done to very high pressure with the same NC balloon. And I didn't have in my cath lab 5 O balloons. And this is our result. Patient now starting to complain of chest pain. I think this is due to the dissection is extending to the diagonal branch, the first diagonal branch. So if you look at this one, I think he's starting pain from this one. So I start the patient on agrastat, PCI protocol, isocative fusion, morphine given, and also I keep our surgeon backup. Most likely extending to the dissection to the D1. This is the ECG post-stent. Everything is okay. Patient CCU, no chest pain. Second day, also the ECG the same, no new changes. Patient follow-up 1 week, stable, no chest pain, and we decrease his antihypertensive medication. And after, I think, 2 years later, patient lose his weight, stop smoking, and he is working about 3 to 5 kilo a day. His kilometer a day, his ECG is returned back to normal, even the LVH criteria, not on the ECG now. And after 3 years later, the patient come to me with chest pain. At this time, I didn't send him to the cath lab. I do for him a coronary CT angio. Our coronary CT angio showed that a large vessel, there is overlapping stent deployed from the origin of the left main to the LED. All stents are well deployed and fully patent. The most proximal stent covers the origin of the left main and protrudes 1 to 2 millimeters onto the aorta. It's short and overlap the second stent inside the left main. The overlapping segment is 7 millimeters. The second and third stent overlap the origin of D2 branches. The overlapping segment is 4 millimeters long. The distal LED is normal. D1 and D2 are stent gelled. The D2 has a moderate osteal stenosis. The circ is patent and the RC is good. There is a non-severe stenosis. Thank you.